Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Thank you for joining us for episode 2 of this clinical clip titled Key Breakthroughs in the Treatment of Primary Biliary Cholangitis from the European Association for the Study of Liver EASL Congress 2025. My name is Dr. Nancy Reau, and I'm Section Chief and Professor of Medicine at Rush University Medical Center in Chicago. In this clip, I will highlight key data presented at the conference in Amsterdam. The first presentation I'd like to address was presented on Friday, addressing steatotic liver disease, and does this influence treatment response and clinical outcomes in primary biliary cholangitis? This study looked at the global PBC registry. They defined steatosis by a CAP score of greater than 280, and over 20% of the patients had concomitant steatosis. Those patients had, as expected, higher BMI, type 2 diabetes, enriched in hypertension, but there was no difference in liver spleen and liver stiffness measurements, and specifically, there was no difference in the number of individuals with a liver stiffness measurement greater than 14 kilopascal or associated with significant fibrosis. They also had lower APR and FIB4 scores than the non-steatotic cohort. They looked at the impact on response. And oddly, there was a higher chance of biochemical response in those that had concomitant steatosis and no difference in liver transplant rates, liver-related morbidity, or mortality. So although I'm not sure that having concomitant steatosis is a good thing, it does suggest that having steatosis in a patient with PBC may not confer that same risk of more aggressive disease that we see in other disease states. The second presentation that I'd like to address looked at statin use and its association with decreased risk of disease progression and death in non-cirrhotic patients with primary biliary cholangitis. This presentation concentrated on 2 centers in Greece, and they evaluated to see if statins had an impact on disease progression. They had 466 non-cirrhotic individuals in this cohort, 237 of which had a statin. These patients obviously had higher lipids because this was not statin use for their PBC. And on biopsies, there was a higher rate of steatosis, as you would also expect in a group that's enriched in hyperlipidemia. But they saw no difference in treatment response or the use of ursodeoxycholic acid, or the difference in use in fibrates. So that second-line therapy and the choice of second-line therapy did not seem to be dictated by statin use or hyperlipidemia, although there were very small numbers in those that had fibrates. They did find that those individuals that had statin use had better outcomes. So this was taken over a long period of time. And the group that also received a statin, remember, no one had cirrhosis at enrollment or at initial observation. They had less progression to cirrhosis, and they had lower rates of liver and non-liver related death and decompensation. So all cause as well as liver-related mortality was improved with statin use. Now, this does not mean that we should use a statin for all of our patients with PBC, but I think like many other liver diseases, we should not be afraid to use a statin in a patient with PBC who has hyperlipidemia and clear indications for statin use. The next study was a presentation addressing the utility of splenic stiffness as a predictor for varices needing treatment in autoimmune hepatitis and primary biliary cholangitis. So not just PBC, but also a cohort of AIH. This presentation looked at applying the Baveno criteria because they are not well validated in an AIH or PBC cohort. So the aim was to validate the Baveno 7 criteria and to see if spleen stiffness could be helpful. And they used 2 large Barcelona centers to help validate this. All patients had cirrhosis, and they had 45 patients with PBC and 70 patients with autoimmune hepatitis. 24% had large varices in the PBC group and 19% in the autoimmune group on upper endoscopy. Nearly all patients were in biochemical response in both cohorts, and that's important because we would certainly expect to see more portal hypertension in a group that has more inflammation on histology. Liver stiffness was lower in the autoimmune patients versus PBC, and what we also saw is that in PBC patients, large varices often were associated with a liver stiffness measurement less than 20 kilopascal. So they wouldn't have been selected if we were going by Baveno 7 criteria only. They did have lower platelets and a higher spleen stiffness, generally greater than 40 kilopascal. So the mini test to identify large varices in this group of patients with PBC, spleen stiffness had a very good correlation at 0.87 AUD when combined with the Baveno 7 criteria. This was best if you also added platelets, and they felt that showing that spleen stiffness and platelet count would reduce the number of upper endoscopies needed so that you could identify these individuals and give them a non-selective beta blocker rather than do an upper endoscopy. The results were a little different in the autoimmune group. Here, 61% had liver stiffness measurements less than 20 kilopascal, and 38% had a spleen stiffness less than 40 kilopascal, but platelets were the best test. Their AUD was 0.88. So that means that both liver stiffness measurement and platelet count, that means that both liver stiffness measurement and spleen stiffness were not that predictive, but platelet count here was. They felt that combining platelets with other non-invasive tests did not improve the ability to predict large varices. And this is a little different than our dogma. We normally think that platelets alone, and our guidelines would suggest that platelets alone are not good enough to help identify patients with significant clinical portal hypertension at risk for significant varices that might need a non-selective beta blocker. So I think that these numbers are small, and it'd be nice to see this demonstrated again in another cohort. But a suggestion that there might be non-invasive tests that can help us identify patients at risk with autoimmune and PBC, two prior disease states that have not been well validated. The next study I want to cover is the FIOCA study. This was a comparative analysis of transplant-free survival in primary biliary cholangitis patients treated with abetacolic acid or fibrates. We recognize that it's increasingly difficult to identify patients that need second-line therapy and when to start second-line therapy. And again, this study is looking at some of our older second-line therapies because of the time of recruitment into the trial. They used the global PBC cohort, and they used an estimate or a Cox proportional hazard model to evaluate the risk for transplant-free survival. They had 1,333 patients, 646 of which were on abetacolic acid and 685 on a fibrate. 87.2% were women with an average age of 57, which is not unusual for this type of patient population. But what is a little unusual is that patients on abetacolic acid were more often cirrhotic, 30% compared to 19%. And remember that OCA with cirrhosis, especially with clinically significant portal hypertension, is certainly a cautionary tale. They did find that some of these patients had significantly increased alkaline phosphatase or increased bilirubin. And the conclusion was that the study really demonstrated no difference in transplant-free survival in patients treated with either a fibrate or abetacolic acid. But they did find that established cirrhosis, as well as more aggressive disease, demonstrated by a higher alkaline phosphatase, were independently associated with worse outcomes. This is important because when you're using an agent, and you're using a surrogate such as alkaline phosphatase or bilirubin to predict something that you don't want to happen, but if it does happen, it's going to occur years down the line, you really want to make sure that your surrogate is reflecting appropriate risk. They really felt that this study emphasized the importance of early access to second-line treatment, which is increasingly available now that we have more treatment options, and our guidelines are more permissive in how we define a person who's needs a second line therapy because they're not in biochemical response. And when we do that, historically, we might have waited a year or more before we identified someone who was not having successful treatment. And now we know that we can move that up to at least 6 months, maybe even possibly sooner. The next study I want to cover is really important. This looked at the safety of Seladelpar in patients with PBC, cirrhosis, and clinical signs of portal hypertension. And this used data from both the ENHANCE and RESPONSE studies. So it's important to know that neither one of these studies it included patients with clinically significant portal hypertension. But still, when you're recruiting a large group of individuals, there are patients who have some portal hypertension, even if they didn't have decompensated disease. So in these two phase 3 placebo-controlled studies that excluded patients with decompensated disease, Seladelpar was demonstrated to significantly improve cholestatic markers, improve pruritus, and they were felt to be safe. But this study specifically pulled out the safety data from the subgroup that had cirrhosis and clinical signs of portal hypertension, which were really defined as imaging with significant, varicosities, but or thrombocytopenia or high CAPS, high liver stiffness scores. But again, they could not have encephalopathy, they could not have variceal bleeding, they could not have clinically significant ascites. In this study, there were 56 patients that had cirrhosis at baseline, and 27 had signs of portal hypertension. 21 were on Seladelpar and 6 on placebo. The majority of the patients were female, 85%. 90% were white, and the average age was 55.6 years, which you would expect for this type of a population. The individuals were well compensated. So the mean alkaline phosphatase was 319 and bilirubin of 1.2, and the mean liver stiffness was 17.4 kilopascals in the placebo and 21.0 kilopascals with Seladelpar. Now, these are very small numbers. So we're not able to use this to expand the treatment indications for Seladelpar. This is really for more reassurance that patients with clinically significant portal hypertension, but not decompensation, can be treated safely with this agent. So that they did find that in a group of patients with cirrhosis, there were some clinical events. There were some even liver-related events, which were not necessarily decompensation in all patients, although one patient did develop ascites, which was presumed to be from progression of disease and not a side effect of the medication. However, there were no treatment agent associated events. So in this pooled analysis of patients with PBC and cirrhosis and that small subset with clinical signs of portal hypertension from the enhance and response studies, it was felt that safety outcomes were similar between Seladelpar and placebo. And again, you cannot use this to expand use of the agent into those with clinically significant portal hypertension and decompensation. But I think it reassures us when we're treating our patients with cirrhosis that this agent can be used safely. Prognosis is really important for our patients, and when we're evaluating the response using surrogates and adding second line and sometimes you may be even considering third line therapy, you want to make sure that we are doing these algorithms in a way that actually impacts outcome for the patient. So this is a study that looked at evaluating the response of second line treatment with Bezafibrate in patients with primary biliary cholangitis. This study occurred in 400 patients that were recruited from the Spanish COLHI registry, which included 37 different Spanish centers. They used response criteria, so the various different scales at 1 year treatment with Bezafibrate to predict transplant-free survival and to help them come up with a predictive score and to assess response to Bezafibrate. They looked at event-free survival, which was really what you would expect for someone who's progressing. So that means no decompensation, no hepatocellular carcinoma, no progression to liver transplantation, and no liver-related death. So in this cohort, like a standard PBC population, most were female, 89%. The median age was 56%. 11% or 45 had cirrhosis at baseline, and 15.5% were also on third-line A-beta-cholic acid. The median treatment time for Bezafibrate was 3.8 years, and some of them received multiple years of Bezafibrate. During follow-up, 51 or 14% developed liver cirrhosis, 7% decompensated. There were 5 that developed liver cancer and 2 that had liver-related death, along with 14 that went on for transplantation. And so of these, they looked at multiple different treatment sets and scoring and developed, what they felt would be a good way of assessing treatment response and risk for for progression. They did find that the Paris-2 criteria had high sensitivity. So patients who responded based on Paris-2 criteria rarely experienced events. However, if you were a non-responder according to the PARIS-2, then the GLOBE score, if it was less than or equal to 0.35, had excellent event-free survival. So therefore, they felt that a third-line therapy might not be necessary if your GLOBE score suggested that your outcome was going to be good. The POSE criteria, unfortunately, had low accuracy to evaluate response after benzafibrate. And when we looked at the variables that looked at response, they found that AST, ALT, and total bilirubin, but not alkaline phosphatase, which is definitely a one-off, were associated with response. The last study I want to cover was a presentation on Elafibranor in primary sclerosing cholangitis, otherwise the Elmwood phase 2 randomized controlled trial. Now, primary sclerosing cholangitis is a very different disease than PBC, but it is still a chronic cholestatic liver disease. And so this 12-week double-blind trial enrolled patients with large duct PSC, so not small duct PSC, and an alkaline phosphatase greater than or equal to 1.5 times the upper limit of normal. They were randomized 1:1 to either elafibranor 80 milligrams, elafibranor 120, or placebo. And patients were stratified based on use of ursodeoxycholic acid. The primary endpoint was safety and tolerability, although additional endpoints included changes from baseline in alkaline phosphatase, ALT, GGT, and markers of fibrosis, such as the ELF and ProC3, and then other things such as itching and other scoring systems. This study recruited 68 patients. Now, different than PBC, there was a predominance of men, so 54% were men. They were randomized in that 1:1 ratio to 80 milligrams or 120 of the intervention versus placebo, and there were a little over 20 in each arm. 55.9, or essentially 56%, had concomitant inflammatory bowel disease, which is important and expected, and 71% were also on ursodeoxycholic acid. 23.5% had an ELF score greater than 10.6, suggesting significant fibrosis. And increased liver chemistries were expected with a mean alkaline phosphatase of 369, a LT of 84, and GGT was 447. Now, because it is mostly safety and tolerability, it's exciting to know that in the Elmwood, both doses of elafibranor were well tolerated with few treatment discontinuations in this population with PSC. At week 12, there was a significant and dose-dependent reduction in biochemical markers of cholestasis, as you would expect if something is working, and the patients receiving elafibranor 120 also had an improvement in pruritus. The effects of elafibranor on liver fibrosis are going to be reassessed in the ongoing 96-week open label extension, so 12 weeks probably wasn't long enough, and we look forward to those, those outcomes and hopefully AASLD. In closing, thank you again for joining us for this episode 2 of the clinical clip titled Key Breakthrough in the Treatment of Primary Biliary Cholangitis from the EASL Congress 2025. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit and access downloadable slides. Thank you again.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.